Yes.
Okay, so the whole study came from the discovery in 1996 by Dr. Folk that some female sex workers in Nairobi, Kenya were actually kind of resistant to HIV infection. So despite being exposed by the virus, they are not being infected. And while now there's new protection method, we still see the same thing, like Dr. McKinnon saw the same type of behavior, that after 3 years within sex works, really the risk of being infected by HIV diminished over time. And so over the years, we tried to find out why those women were naturally resistant to the infection. And we could not find one factor, but what we kind of observe is an immune picture. So how their baseline immune system looks like. And overall, what we saw is that at the genital tract, those women have a more quiescent phenotype. So that means that their immune system is less active. So they have less CD4 T cell that are active, which is the favorite target cells for HIV, but in the same time they have more Tregs, so they are able to control more the infection, the inflammation, I should say, and also have less inflammatory cytokines and chemokines to call activated T cells. So we were like, oh, that's great for them, but what for other women? If it's a genetic factor, we cannot help other women. So what can we do to help older women to maybe have that phenotype? And so we decided to look if we can induce that phenotype, so mimicking that quiescence phenotype in other women. And we decided to try that by looking with anti-inflammatory drug. So what we looked for was that drug was safe. They were already FDA and Health Canada approved. That were affordable. So we wanted something that every woman around the world could afford to have, and were accessible everywhere, and also acceptable to take. And so we choose for the first study 2 drugs. One was HCQ, so the famous hydroxychloroquine promoted by former President Trump for COVID, and aspirin. HCQ didn't really work in our pilot studies, so I'm gonna talk mostly about the aspirin. We all know aspirin is available everywhere in the world. It's mostly for treating for headache, fever, and pain. We also know after cardiovascular disease, a low dose is given to people every day to kind of prevent stroke. And so we know that the 81 milligram a day is very safe. And we did some community meeting, and we found out that taking an aspirin a day was highly acceptable for the population in Kenya. And they also were liking the fact that it was not stigmatizing. They could have that at home without any problem or any kind of misinterpretation about having that drug at home. And so when we did the pilot study in the Pumwani district, so that is women who are not female sex workers, so they are considered as low risk. And what we observe is after 6 weeks on taking aspirin, we saw decreasing of HIV target cells. So the cells who are carrying the CCR5 receptor or the Th17 CCR5 positive target cells at the female genital tract. And when we compare through baseline and after 6 weeks, we observed that the level of target cells at the female genital tract with taking low dose aspirin was becoming pretty close to what we observe in female sex workers that are resistant to the HIV infection. So we're like, well, that's great. Like we have something, we might, let's see if we can push that. And so we developed a new study, that's the CTN study that we are talking about here. It's in female sex worker this time. The goal is to enroll 300 participants. So 100 participants will take 81 milligram a day of aspirin, 100 participants will take the 325 milligram a day, and 100 participants who are the control group. The study is going to be over 6 months long and 2 follow-up study for a month. Here you have like the list of the samples we are going to take. So blood samples and vaginal samples throughout all the visit. And at pre-screening, we are looking at liver and kidney function as well as STI to make sure they are and we can enroll them. Then at baseline, we are doing all the science and so on. It was really expensive to do science in every visit, so we will do science at 3 visits during the time that from baseline and up to the end. And we are going to also look at microbiome and all impact and inflammation, cytokines and chemokines. And recently, Keith was in Nairobi, and he conducted some meeting with the community and with the peer leaders of the female sex worker to talk about the study and get their input. And overall, we have a really strong commitment from the community. They are really supportive of the study. And so recruitment update. So until now, we assessed eligibility on a little bit over 200 participants, pre-screen a little bit over 100 and enrolled 26. We are already starting to be like in time. So we have started to have some in visit 4. And you have why most were excluded, and most were excluded because of present of STI. So we are training them and hoping to be able to enroll them later on. And so thank you. I want to thank the participant from the pilot study and also from this study, the peer leader from the community, the Nairobi team lab and Keith and all the folk labs. So thank you.